Hey class, thank you very much for taking time to watch this video today. I have Molly here, and she's going to share a little bit about herself and social work and where she got her degree and where she works and kind of the things that she has. I think this will be a really powerful segment, so thank you for tuning in. We're going to be discussing a House bill and policy that I think is very important and has a lot of ramifications for all healthcare providers as well as social workers. So Molly, take it away. You might share with my students who you are and what makes you tick and where do you work and how did you get there?
Sure. Thanks, Gray, for allowing me to join. Hello, students. And I am Molly Ticknor. I am the Executive Director over the Missouri Show Me School-Based Health Alliance. Just a little bit of background on the Alliance. We are the Missouri affiliate for the School-Based Health Alliance, the National School-Based Health Alliance. So our work is really in building, helping, creating partnerships, and sustaining school-based health programs across the state of Missouri. Looking at the physical, mental health, oral health, and vision care that we're providing students in the schools, making sure that all students have equitable access to quality health care. And one of the biggest platforms is the policies. So we do have a policy advocacy committee that is comprised of many individuals across both sectors in healthcare and education that really focuses on legislative actions that are coming through and administrative policies that potentially will impact school-based health, both at education as well as the healthcare lens. And so we are staying abreast of all, different policies that are going to come down the pike that could potentially benefit and or be a threat to the school-based health or the education system for our students. A little bit of background, my degree is actually in art therapy and I'm a licensed professional counselor by trade. So I started my career working in residential and working with some at-risk youth and teens here in Kansas City at a local residential facility, and then moved into the outpatient world at Truman Medical Center Behavioral Health, where we really focused on meeting the needs of the inner city community here in Kansas City. Then became a team leader over the therapist and the case manager. So really bridging the gaps between the healthcare world and the education world. I also led the Trauma-Informed Care and Trauma Sensitive Schools Initiative in the Kansas City region under Truman Medical Center Behavioral Health, and which led me to a position at Kansas City Public Schools as the director of healthcare. So I was over all of the school nurses and all the mental health and social workers that met the needs, mental health and physical health needs of the youth, which led me to my position that I have today as the executive director over the Alliance. I've been in this position for about a year. It's really exciting to be in this position because I get to take all of my experience, the frontline experience that I've had and my supervisory experience, and really look on systems change and how we can really focus on the healthcare needs of Missouri kids.
You know, when I was a graduate student, in my head, I just was thinking about I wanted to be a residential therapist. And I said a little prayer to the policy gods. I said, please let me pass this class, and I'll let policy be for people who are smarter than me. But the interesting thing, and I think your career is a really great example, you started very much in the trench as a clinician, but as your work grew, you went from the micro to the meso, now to the macro level. And so for my students out there that are dreading this class, there is light at the end of the tunnel. And when you connect policy to practice, it all of a sudden makes all the sense in the world. And I should have been paying more attention to policy the entire time instead of wasting my youth being a residential therapist. So there you go.
Yeah, and especially as a direct provider coming in, as a BSW or an MSW, you see things that could implement change. And so one of the things that we really focus on in our committees and in our work that in recruiting board members and volunteers, we want to make sure we have direct providers representing because we want to hear what's going on in the field, because that will inform and what happens at the policy level. And to be completely honest, the representatives at the state and the federal government and your local representatives don't really want to hear from me. They know me, but they'd rather hear from the constituents. They'd rather hear from the people that are doing the work, because then they're hearing those real life stories, and that's where it really gets them ticking.
Absolutely. So we're going to talk today, students, about House Bill 1719 that went into effect at the end of August of 2018. And the requirement is that all healthcare providers in the state of Missouri, so LPCs, social workers, absolutely, as well as everyone else, needs to have 2 hours, 2 CEUs of suicide awareness and suicide treatment, suicide, planning. And I think this, first off, and I would imagine you would agree with me, how is this not a requirement in every state? Again, we don't have to go down that path. And the truth is, when a client says to you, Gray, I think that my family would be better off without me. And my response is to then say, oh, well, I think you need to go to Crittenton and be evaluated. Does that over time give the message that I don't really have the tools in the training to even address your issue? And I think the sad part is, and which is I think what helped this legislation come to light and then, get some legs on it, was that, yeah, a lot of healthcare providers didn't have the training. We would send people to Crittenton or Research Psych, and then rather than to sit down and really, help our clients. So again, and I don't think I need to overstate, and hopefully my students will be aware of the significance of suicide awareness and training. It is a leading cause. In 2015, it was the 10th leading cause of death in the state of Missouri. I don't know where the statistics are right now, but it continues to be very high. And teens and preteens are not exclusive to this. They are also at risk. So obviously it's an important issue for the School-Based Health Alliance. So that's a whole bunch of nothing I just said. So what are your thoughts about that legislation and that policy, Molly? And was it long overdue, and how was it received?
Definitely. I think, Gray, to your point, it was extremely long overdue. I think that we do a disservice to our students who are going into the counseling or social work field, that we don't prepare them for this. Speaking from experience, when I graduated from my master's program, I didn't even have a suicide prevention class.
No, yeah,
That was something that was
me
taught to me. That was something that was taught to me in the trenches when I was working as a counselor in residential, and so by my supervisor. So it wasn't until I had that clinical supervision where they started to look into that, and they started to look at some evidence-based practices. So it excites me that now most programs, in my knowledge anyway, require some sort of level of at least training at the collegiate level. So the fact that this law has now passed, I think supports that, to give, so that when people come out of school, they're at least competent to understand what are the warning signs, what are the symptoms, what do I do, how do I respond. I might not be the one that will treat them, in the future, but at least I can do that triage and that assessment to determine, is it truly imminent? Do they need to go to the hospital? Because the reality is we have so many hospitalizations. Our ERs are overwhelmed. Our inpatient units are overwhelmed. And now that we have given the tools, hopefully, to these students and given them almost, they're mandated to have this training, hopefully that'll prevent some of those useless hospitalizations where they could have really intense outpatient treatment. I think it also helps build relationships between the clinician and the client, because like you said, that competency is extremely important.
Right.
To know and to have, like, not necessarily you're the expert, but I'm in this with you. I can help you respond. I can help you cope. And we can find some of those internal and external supports so that potentially you do not lead to harming yourself or attempting suicide. So at the policy level, this is something that we have advocated for. And I will tell you, in the education world, DESE, the Missouri Department of Education, second elementary and secondary education, also last 2018 put a policy for all of the public schools, charter and public schools, to have written suicide prevention policies, as well as the ability to treat and the ability to address when suicide attempts or when someone threatens suicide. So they either have to have it internally or they have to be able to have relationships with an outside provider that has these skills and the skill set to be able to assess and refer and have those connections. So it does definitely bridge that gap that we've been seeing where oftentimes school districts would just, a student would say, I want to kill myself, and then immediately we call 911 instead of calling, a crisis line, or instead of calling in a clinician that I have a partnership with who has the expertise to do that on site in the moment so that the student can get treated immediately and not have that gap. Because the other thing that we're seeing is once they go to the hospital, especially some of our teenage youth, they might not be imminently suicidal at that moment. And so it's hard to justify, yes, they truly do need inpatient treatment because we didn't do that assessment, right? We didn't have the skills to take that training and know exactly what questions to ask or what questions not to ask and how we address it.
And then that creates a little chasm, and then those clients and students can fall down into that chasm. At that moment, if you're not suicidal, you may not get admitted, and then where's the follow-up and the treatment? I am
Right.
I very quickly, I'll share a case that I had. It was a private practice case. I was doing in-home work. This young girl was 13, living with her uncle and aunt. They had guardianship, and the school called the aunt and said, she's, Becky, whatever, Becky has been cutting on herself, and she's made some, suicidal statements. So the aunt called me. I wasn't scheduled to be out that night, but I said, I will clear my schedule. I'll be out. So we had a session in the home. We safety planned. She did admit she had cut herself. She admits sometimes she thinks she's a burden to her family. She wasn't actively suicidal. So I said to the aunt, what do we do? Because I want them to be a partner to the process, and the uncle is there. And the aunt says, well, she's not going to school tomorrow. She can easily go with me to work. She can, we'll take her schoolwork. She'll be with me. I'll have eyes on her 24/7. Tonight, she is going to sleep with me in my room, and I'm going to take the door off her bedroom so that we have eyes on her. And I said to the young lady, I said, are you okay with these things? And she said, well, what if I'm not? And I said, well, if we can't safety plan and triage and make your aunt and your uncle your co-therapists, then you'll have to go, to Marillac or Crittenton. And the girl said, no, I'm really willing to do these things. So we did all of those things. I did follow up, and she was doing great. She went back to school 2 days later. So a week later, they went in for their psych appointment just to update their meds. Of course, the doctor said, how's it been going? And the aunt said, well, we had kind of a rough patch about 10 days ago, and kind of shared what happened and how we triaged it and how it took care of itself. And the doctor's response was, that's the biggest bunch of crap I ever heard. She should have gone immediately to the hospital. And the aunt's feeling was to feel devalued by the psychiatrist, and that she felt a little defensive of me. She's like, how are you going to throw him under the bus? He came out, he was right there, he was in the trench with us. And so her response was to change psychiatrist. So that whole process of you need to immediately go here felt very devaluing to the client. And the psychiatrist did that in front of, Becky, the 13-year-old girl.
In front of the student.
And so you're absolutely right. We've got to do more training, because this is not an issue that's going to fix itself or go away. So that our clients feel valued, whether it's at the school level or any other level, because we're creating these chasms, and these kids are falling down into these chasms.
And we've done a lot of work at the school level, Gray, to help, at least the school district that I worked for. We did a lot of work on not only training our licensed professional counselors and our clinical social workers in doing a brief suicide assessment and screening, but we trained all the school nurses and all the school counselors and all the, the MSW students and the caseworkers that worked. So, this legislation, hopefully, I know it's for clinicians, but hopefully this legislation will push schools and organizations to think about not just training the ones that are going to be doing the ongoing treatment or the assessment, but those that can do triage, because they do have screening tools that, with a little bit of training, someone that has a little bit of medical or mental health background can do, which could save a moment. Because I might disclose to my caseworker something that I might not disclose to my clinician, or I might see my caseworker more often, to your point of being in the home. So I think this legislation really can kind of help organizations start to plan of how they not only train their clinicians, because now it's mandatory, but how they train other staff that do support the mental health needs of their clients and students.
Absolutely. And in addition to that, right, um, kids are more comfortable in their classrooms, and they're going to
Right.
share things with their teachers. And so we have to create this link so that we're all, moving forward to address these issues. So you know, now one of the things about this House bill that I feel really strongly about, and we'll compare it to the Kansas law that requires safety training. That is a one-time deal. This particular House bill says every 2 years you have to have 2 CEUs, so it's continual. And I think that is really key. Is that something that made sense as it was rolling out to you into your agency?
Definitely. We actually, funny you asked that, because we actually pushed for that as far as our advocacy efforts, both when I was working at the school district and then now at the Show Me School-Based Health Alliance, because best practices change. And we want the training that our clinicians are getting and our counselors are getting to be current, and policy changes. And we want to make sure that they're abreast of what is happening. I mean, if you go back to when I was practicing, I'm not going to tell you a year, but things have changed since then. I mean,
Absolutely.
the way that we assess, the tools that we use, the trauma informed care model, like that all changes the way we address. And so that has to be incorporated into our training. So the fact that individuals have to be trained every 2 years will ensure that they're getting the most up-to-date information, so they feel comfortable and competent to be able to deliver that, that treatment.
Yeah, I think that's such a valid point. Um, Once a policy is rolled out, it doesn't mean that it's a done deal. We need to constantly be evaluating it, and because down the road our lenses will change. I know when I started at the Gillis Center in 1988, I couldn't have even defined what trauma meant, much less the impact and the adverse childhood experiences, and we didn't even have the language of trauma informed care, and it wasn't until 20 years later. So where are we going to be 20 years from now? But suicide is still going to be there, and so we need to constantly continue to revise our tools, keep them fresh. Well, I really appreciate this. Before we sign off, are there any other policies that are sort of on the table that are that you might want to take a moment to share with my students? Because
Sure.
you definitely have your finger on the pulse in Missouri, and I know my KU students, they'll be like, Missouri, if you live in Kansas City, you've got to understand both states and be licensed in both states. So I think this is still very relevant, even for a Kansas student. So
Yep,
any,
definitely. And to that point, Gray, our families are extremely mobile. The
absolutely. Oh yeah,
mobility rate in the urban core is up to 35-40% going across state lines. So even if you plan on practicing in Kansas, the chances are that your families or your clients are going to move across state line to seek a better school district or a better job opportunity or a home is highly likely. So I highly suggest that, yeah, the students keep a pulse on what's happening on both sides of the state. The,
absolutely.
the, the legislation that has passed in Missouri is called House Bill 1414, and it's going to be sitting on the governor's desk hopefully very soon for him to sign after the 4th of July. It specifically addresses homeless youth in Missouri and their ability to access their medical records, their mental health records, as well as to seek treatment. Previously, you had to be 17 or older to be able to seek your own mental health treatment in the state of Missouri, and now you can be 15 or higher. So those that, the state of Missouri declares youth that are homeless, whether they're an unaccompanied minor, they're couch surfing, they're living with a significant other and they don't have a permanent residence, or there's not some sort of custody agreement. So that's a large percentage of our youth, especially here in the Kansas City region. This is huge for them. It also gives them the ability to access their birth certificate, to get a free copy of that, because we know that's needed to apply for a job, to get
Absolutely.
assistance. It also helps them be able to apply easily for Medicaid and SNAPs once they do SNAP, or once they do fall off of fall out of the system. We are continuing to advocate for those kids that are in foster care when they age out of the foster care system, or they do get adopted, that they can maintain their Medicaid benefits. That's one thing that has not passed yet that we're continuing to advocate for. I think because of the growing homeless youth in this area, that it's extremely important for students that are coming into social work to really truly understand some of that legislation, so they can better help support the most at-risk students that we have, the most at-risk clients that we have in our community.
Well, I'll make sure in my online platforms to include a link to House Bill 1414 so we can read about that. Was there much opposition as those went through committees?
We had really great support from one senator and one representative, and it did a little. It took some work. This was actually the second time that it was brought to a committee. I think that honestly, the hard work that our legislative advocates have put in, and COVID-19, even though it has been a barrier to a lot of things, it actually shed a light to a lot of the gaps and the barriers in our education and healthcare system. So that honestly, I think, helped a little bit to bring it back to light, and help the committees and the House really determine, make it a priority.
You know, Molly, you while you were sharing, I thought of something that I thought I would wrap up this video with. Recently, I toured the National Orphan Train Museum in Concordia, Kansas, and I wasn't really sure what I was going to experience. I will say it was an extremely worthwhile trip. Being passionate about child welfare and child welfare issues, it definitely spoke to me, and I know that's this same population for you. So at the museum, there's three buildings. There's the general building, which is the library and the research, and it's where you go in and you check in, and there's a bookstore in there. You see a little movie about the orphan train that occurred in the 1800s. Then there's a building that has a train car in it, and then there's the depot, and then the depot is the story of multiple orphans that made their way out to parts of Kansas, found forever families, and their stories of their lives. So really powerful. So in the second building, when you're in the train car, they have the train car set up with these vignettes. So you could imagine what it was like for an 8-year-old on the train, coming across the United States. And one of the first vignettes, there's a little place card, and it says, as kids were leaving the orphanage in New York and being put on the train, all of their possessions were taken from them that they came to the orphanage with, whether it was pictures or a book or a stuffy. And they were given a suitcase, and in the suitcase was a Bible, a toy, not their toy, a change of clothes, and maybe some snacks. And I'm reading that, and I think to myself, holy cow, we're in 2020. And I think we can all agree how traumatizing that might be, to take the child's pictures of their family, or maybe a book that their mom had given them, and take it away from them. And yet when I think about what constantly occurs in child welfare in residential, I more than once, saw a young man or a young woman, act up, and then the staff would go in and just empty her room. They'd take away all of her stuff. And then sometimes she might not ever get that stuff back, or it would get displaced or lost. And there might have been a blanket in there that was her blanket that her mom had given her when she was like 6. And how traumatizing that is. So from the 1800s to 2020, have we not learned anything? But I'd like to believe we have, but in some aspects, we're still doing the same goofy stuff, you know?
It just looks different, and I think about all the times in residential or even with our homeless youth currently who have trash bags. I
Yes.
mean, they come to residential, they come to foster homes with trash bags. And so that, what that feels like and what that demoralizing, like I'm not even a human being. I mean, you think about the train, they were put in a train like a piece of meat or like I mean, it wasn't, just that like you're being shipped across the country in a freight train. And what we do currently in our system. And I think that's where the system reform needs to look. And the advocates that we have, there are so many great advocacy agencies in Kansas and Missouri that are trying to focus on these most high risk, vulnerable youth. And making sure that we're hearing the voices, like you said earlier, of those youth. We're talking to them, we're engaging with foster parents, we're engaging with those youth that have aged out of the system about what their experiences were and what we can do to make the difference. Because like I said, at the policy level, those individuals are the ones that the policy makers want to hear from. They want to hear those stories. So individuals like caseworkers and MSW students and BSW students who are coming down our educational pike, holding dear to those stories and being the voice for those students as policies come up to be able to share, like, it, we have come a long way, but I think we've just done it differently. Things look different, but we're still practicing some of those similar, we're some of those similar practices that just scare me when we think of the youth and how they're brought up and how they're raised in systems.
Well, today's BSW student and today's MSW student are future policymakers.
True.
And so it's just got to be, it's got to become that passion. We can't just all be therapists. We also need to be advocates and stand up for those who aren't, being heard or stand up for themselves. So, well, thank you so much, Molly. I so appreciate it. I'm going to include some links to House Bill 1414 and also some links to the Missouri School-Based Health Alliance so students can learn more about it. Students, if you have any questions, please shoot Molly an email. I know she'll be glad to answer any questions. And thank you so much.
Well, thank you very much, Gray.